So that brings us to the end of this session, but we are now getting ready for the keynote lecture, so I can request all the panelists to go and get their seat. Dr. Caraballo, if you can just stay on here. Now, I have a daunting task to introduce to you guys a person who requires a book to summarize his accomplishments. I don't know where to start and where to begin. Only thing to say that I have had the privilege of being his student and he being my mentor. How do you introduce a person who has clinical science named after him in cardiology? We have Carabello's sign in his name. But just to briefly tell you an idea of those of you who don't know him, because in cardiology everyone knows him, all you need to say is Blase Carabello. That's full CV. Everyone knows who he is. But for those of you who don't, I'll just summarize a little so that you get an idea of the personality sitting here. Blase Caraballo is an internationally recognized expert wwho trained, did his residency and fellowship at Harvard. After that, he has been in various research positions and clinical positions. He has authored more than 250 peer-reviewed articles, has had more than 200 book chapters and editorials. He has also received numerous national awards. Some of them you can mention here as the prestigious Distinguished Scientist Award, Master Clinical Lifetime Award, and the Harriet Dunstan Award for Science Related to Medicine, which is a national award given in 2020. He's the past president of Society of Heart Valve Disease and the Association of University Cardiologists. And in 2017, he was named the John Jack Rose Distinguished Professor in Medicine. But above all, what I know him as, I have never met anyone else who can distill complex hemodynamics and complex medical concepts into such simple lines that you will never forget in your lifetime. And that's why he's a master educator as well. His hemodynamic rounds are legendary. But above all, he has a razor-sharp sense of humor, which ought to be registered in the state of Texas as a lethal weapon. Because if you're on the wrong side of it, you will never forget him. Ladies and gentlemen, it is my distinct pleasure and privilege to introduce to you the keynote speaker for today, Dr. Blase Caraballo, who will be talking to us for low-flow, low-gradient aortic stenosis. Just so that we recognize your presence here, sir, Dr. Marwan Jumian will just give you a token of our appreciation for accepting to speak. Thank you. Marwan.
This is just a token of appreciation. I'm going to add one more thing to what Dr. Carr said. He is an extremely responsive individual. Just talking to him on email, down to earth. It is my pleasure to just have you here with us as well. Thank you very much.
Well, you're very kind. Yes, BK, thank you for that very gracious introduction. I wish my parents had been here for that. My father would have enjoyed it, and my mother actually would have believed it. You know, it truly is an honor to be here. This guy I mean, I'm a valve guy. Till yesterday morning, I thought that shock was something that happened in the EP lab when things went bad. So I was sort of saying, well, what could I say to this group that might be helpful? And low flow, low EF, ES, AS is sort of close to this field. And the question is the EF ever too low or the gradient too small for the patient not to be able, with aortic stenosis, not to be able to benefit from an aortic valve replacement? Of course, the answer is yes. It's just a question is, where is that? You know, BK promised you bits of learning that you'll never forget, and here it is. And it turns out that in aortic stenosis, it doesn't matter why the heart can't pump blood, whether it's preserved ejection fraction or reduced ejection fraction, that low flow has a bad prognosis. And in this amalgam of studies, that red line, that red diamond is always to the right of 1. Hazard ratio is increased universally when cardiac output is reduced in aortic stenosis. But it's embarrassing how little I've learned in 42 years, but this is probably still true, that there are 2 ways to get to a low EF in aortic stenosis. The horizontal axis is wall stress, systolic wall stress or afterload. And as afterload goes up, ejection fraction goes down. And that group of patients is a walk in the park. Their EF is reduced because the hole was too small, the afterload's too high. You fix the valve and they get better. In fact, they'll get better in the operating suite or in the hybrid cath lab. Their EF improves immediately when you relieve the afterload excess. The problem is that small group of X's. Their reduction in ejection fraction is not due to increase in afterload primarily, but rather due to some cardiomyopathic process. And the question is, what can we do to help them? Now, in that small study, it appears dichotomous. It almost certainly is, and rather it's a continuum. On the upper left are people who have primarily afterload mismatch, and on the lower right are people who have primarily cardiomyopathy. And where along that line is the sweet spot? Where along that line is the point of no return, where reduction of the afterload or replacement of the valve is not likely to help them? I don't know the answer, but I think we're getting closer to knowing the answer. All AVR does acutely is get rid of the load. Now, chronically, aortic valve replacement and aortic stenosis may lead to improved coronary blood flow. It may lead to remodeling and all sorts of positive things within the myocardium, but acutely, all you've got is a reduction in afterload to make the patient better. And that reduction in afterload, the benefit from that has got to exceed the risk of whatever procedure you're doing. Otherwise, you lose. And so, again, where is that sweet spot? So here's a 72-year-old guy, late stage, 3.5 class heart failure. His sort of soft blood pressure, elevated CVP, 2/6 mid-late peaking systolic ejection murmur, carotids are weak, maybe not delayed. You can't be a neurosurgeon if you can't take a brain tumor out of someone's head. You can't deal in valvular heart disease unless you can do a physical examination. It's not just that I'm old and can do one. You actually need to be able, if you can't tell the difference at the bedside between aortic stenosis and mitral regurgitation, don't do this. Do something else. Because the physical exam provides for you information that you don't get from the echocardiogram, that you don't get from other modalities. It's the feeling, and it is the beginning of Blase's theorem. It is where you first formulate your hypothesis about what's wrong with this guy. And in order to do that, you've got to be able to do a reasonable physical examination. In the echo lab, this guy's a wreck. His ejection fraction is 22%. He's got a very low jet velocity, a mean grading of 22, an aortic valve area that calculates to 0.9, a dimensionless index that's sort of on the borderline. And although we don't have an audience response system, here's we're not talking about coronary disease. Obviously, I had coronary disease, revascularization of hibernating myocardium. You're talking about a whole different thing. Forget that. This is people without coronary disease. And just food for thought. In terms of this guy, he definitely has severe aortic stenosis. The major driver of his LV dysfunction is afterload mismatch. Dobutamine stress echo risk stratifies patients for surgical aortic valve replacement, the same for TAVR, all of the above. The only answer that's correct is C, and you think about that for a while and you see where this is evolving. But the first question is, does this guy really have severe aortic stenosis? Now, the definition, the real definition of severe aortic stenosis is the amount of outflow obstruction that causes illness. That's true. It's not very helpful. How can you manage a patient with that definition. So you understand that I can criticize myself and my colleagues. I've been writing the guidelines for valve disease since we began in 1996. So these definitions come from us. And in order to quantify it more, we said severe AS is quantified as 1,414.6. That is a valve area of less than 1 square centimeter, a peak jet velocity of 4 meters per second or more, a mean transvalvular gradient of 40 millimeters of mercury, or an index valve area of 0.6. Those definitions don't work very well. So that in these almost 3,500 patients, there are a number of patients that fall down and to the left. That means that they have the valve criteria for severe AS, but not the gradient. All right, so we'll say, okay, why don't we make the valve area lower and say 0.75, which is more consistent, by the way, with a gradient of 40. Yeah, the same problem upward to the right. Now you have all those patients on the other side that now have a gradient defined by severe AS, but not the valve area. So, you know, these are man-made definitions, and at least in the current guideline, we finally say typically the valve area is less than 1, but not required to define severe aortic stenosis. The valve area is helpful, but it is not a commandment. It is not a sine qua non for defining severe AS. Now, in terms of, you say, okay, well, what are you going to do with this guy? Well, we could send him to the echo lab or the cath lab and give him dobutamine, because these data from Monin and colleagues almost 20 years ago were very helpful. Group 1 are patients who receiving dobutamine had an increase in their stroke volume of 20% or more, and they did quite well at surgery considering how sick they were, and clearly better than group 2 patients who failed to have inotropic reserve. Okay, fine. However, after that study was performed, the folks in the white bars are the group without inotropic reserve. 30% of them died. Their ejection fraction, by the way, is 0 now. But the group in the white bars had as much improvement in EF even though they didn't have inotropic reserve. And this more recent study looks at the TAVR results with regard to inotropic reserve, and there was no difference in outcome whether they had it or not. Inotropic reserve helps you risk stratify patients for surgery, but not for TAVR. Why is that? Well, in the operating room, if the surgeon can't separate the patient from cardiopulmonary bypass, the first thing he or she reaches for are inotropes. Well, if the guy can't respond to inotropes, you're up the creek. All you've got left then is mechanical circulatory support, which is a problem on its own. So DSE, I'm not saying that it's useless, because seeing these data are helpful. Here's a patient that, given dobutamine, has a robust increase in both stroke volume and gradient, at least confirming in your mind that this patient really does have severe AS. And I think that in some patients it's an important point. But the use of dobutamine stress echo is likely to wane as we do more and more TAVRs and fewer SAVRs. Another adjunct to helping you determine the severity of aortic stenosis is valve calcification. As valve calcium goes up, the valve aperture goes down, and a valve score of 2,000 Agatston units in men and 1,200 in women usually indicates severe AS. Women, for whatever reason, have more fibrosis and less calcium. I don't know why that is, but this is just another adjunct to helping you assess the severity of AS. How did our guy get like this? Guy's sick. His EF is 20%. Where did this come from? I think we're beginning to identify those answers. So if you look on your left, you have a group of patients who started off with what we would call moderate AS, a valve area of 1.4, a reasonably preserved ejection fraction, and a gradient of 30. Over time, they essentially double their gradient The valve area is now 0.8. The ejection fraction hasn't changed very much. They've tolerated their pressure quite well. Our patients on the right, group of patients start off with a lousy gradient of 20. The EF is already low-ish. And with a little addition of gradient, like 7 millimeters of mercury, their ventricle falls apart. Now, some of the reduction in gradient is because the stroke volume's down. But this group of patients, when I first saw that, I thought, why is that? Why are there patients that don't seem to tolerate a pressure overload very well? And I sort of put that aside until this Mayo Clinic study that sort of found the same thing. And the upper panels are people with low EF, and the times on the bottom are the times before they arrived symptomatic requiring a procedure. And you'll notice that the upper group falls off the cliff, not at a valve area of 1, but at a valve area of 1.3. Could it be that there are people, or what are we looking at? Are these two different diseases, or the different response to one disease? Are these people that just don't respond well to a pressure overload? Or are these folks that had some sort of underlying cardiomyopathy, and then engrafted upon that was a pressure overload and they fell apart? But I think I can tell you this from our study in dogs, that if everyone in the audience developed aortic stenosis, and I hope you don't, well, I mean, it's been good for me. I mean, it's put my kids through college and my wife through Neiman Marcus. But this was an experiment wherein 50-pound male dogs underwent a banding procedure in which the gradient was increased by 20 millimeters of mercury every 2 weeks. It's sort of a gradual imposition of pressure overload. Outwardly looking the same dogs, but look in the difference of the myocardial response to what appears to be the same stimulus for hypertrophy. The dog on the left with essentially this nutcracker, incredibly robust LVH, and the one on the right, not so much. And I think all that points out is that our patients with aortic stenosis respond to this disease in many different ways. So to try to make a bunch of definitions for one size fits all isn't possible. It's a matter of using your head and evaluating the patient on a patient-by-patient basis. So going back to that question, is the EF ever too low or the gradient too small for the patient to benefit? Well, so first of all, if you look here, the people with the highest mortality are the people with the low gradient, low EF, and the people with the best outcome are the people with high gradients, and that's what we've been saying all along. If all you need, if they've got a big chance to reduce afterload, then I think that one's easy. As ejection fraction gets worse, mortality goes up, and so the blue bar is for EFs of less than 30, and if you look at the gradient of less than 40 versus more than 40, mortality is worsened as the gradient gets lower. And if you look at the combination of both of them, on your far left in red is low EF with low gradient, and with the blue it's low EF with high gradient. Looking at outcomes, the higher the gradient, the better the outcome. But do we ever get so bad that you can't help the patient? In another study, this time looking at more profoundly reduced EF, now EF's down in the 20 range, they actually had a better improvement in EF post-TAVR than did the other patients. Again, stress echo didn't make a difference. But a key here is that the mean jet velocity in the EF of 20 was 3.25. That's a peak gradient of 40. A mean gradient probably of 30. So this is that. Even though their EFs were profoundly low, their gradients were not profoundly low. So there's some. Where are we going? What is the minimum gradient that we can expect help from? In this study by Tribblewall, a gradient of less than 20 really portended a bad outcome. After all, the gradient's only 20. How much benefit are you going to get from an aortic valve replacement? If you're going to do it, do a TAVR. The TAVRs are inherently more hemodynamically kind than surgically implanted valves. The structure of the valve is different. The platform in which a TAVR is developed is different. It's got no struts, and it is inherently a lower gradient valve than is a surgically implanted valve. So in this, although there aren't data to support it, it only makes sense that in this low gradient group, you need to leave the procedure with the lowest gradient possible, and that's going to be TAVR rather than SAVR. Going back to our patient, this guy with this low gradient, low EF patient, I did something, this is off-label, and don't try this at home, but he had no response to dobutamine. And trying to parse out what's wrong here. In AS, you've got two resistors in series. The first resistor is the resistance offered to circulation by the valve, and the second resistor is that offered by the total peripheral resistance. Giving these people nitroprusside if resistor number 2 is higher than resistor number 1, as you see in the upper panel, flow increases dramatically, and you may even see a rise instead of a fall in blood pressure. In the lower panel, if resistor number 1, the aortic valve, is higher than resistor number 2, the first thing that you need to do is empty the bladder. Yours, not the patient's, because you are going to incur hypotension, but you've also doped out the likelihood of hemodynamic benefit from an aortic valve replacement in our patient with the cardiac output with sodium nitroprusside went from 3.5 to 4.5. The gradient actually went down, and that's not aortic stenosis. So in our patient, I felt quite secure, at least in him, of not doing an aortic valve replacement. The bottom line about answering this question, first of all, we need better tools. We're stuck now with a valve area and a gradient and an ejection fraction. Surely there are things that we could detect in the myocardium itself that would give us a clue. MRI that found a lot of late gadolinium enhancement, a lot of fibrosis, a lot of interstitial edema. That can't be good. And that must be at least a beginning towards getting at the bottom of this. There must be biomarkers that could better inform us about which patients are likely to get better or not. And balloon aortic valvotomy is at least, there are lots of anecdotal experiences, no randomized data, to the use of opening the valve a little as opposed to replacing it, with the idea that a little relief of pressure overload might be enough to encourage the patient to get better if they responded. And then that may identify them as somebody likely to benefit by a full aortic valve replacement. That needs actually a randomized trial of some sort, I think, to get at the bottom of that. So to end, patient with an EF of 20 and a gradient of 47 is a no-brainer. Duh. Don't pass go, don't collect $200, don't lose any sleep, put the valve. That patient's going to have is afterload mismatch, and a TAVR will reduce that afterload and make the patient better. The 30-30 club, less secure. Dobutamine might be helpful, might not. I think most of the patients with a mean gradient of 30 are going to get better after a TAVR. The patient with a gradient of 15, I can't tell you it's justified. It is my sense that that patient is not going to benefit from an aortic valve replacement. That may be consigning somebody to a terrible outcome because of what I think as opposed to what I know. But the 2020 group, I think, is the most difficult and interesting group. And my response to that is throw in everything but the kitchen sink. How does he look? What's his frailty? Did he walk into your office or come in a wheelchair? What's his renal and hepatic function like? Does he have coronary disease also? What's the likelihood of good rehab for this patient? Essentially using a bunch of other factors besides what we don't know about his heart to help us decide. And then you've got to go into him and then give him informed or her informed consent and saying, in your case, here's what I think, but this isn't what I know. But I believe, and then balloon aortic valvotomy in this might be a reasonable thing to do. So I think we're getting closer to understanding the answer to the question, is it ever so bad you can't fix it? We're not there yet, but I suspect with better tools, we will get there, and we'll define a group of patients that are better treated medically than with a valve replacement, and we'll also feel more secure about those people in whom we do elect to perform aortic valve replacement. Well, listen, thank you very much for inviting this valve guy to your proceedings. I've certainly enjoyed being here. I obviously learned a hell of a lot from the previous speakers. I hope you learned something from this. Thank you very much.